Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Steve Rowe. He's healthcare industry lead at 3Pillar. Welcome, Steve.
Thanks for having me.
Yeah, so I think we have some exciting conversation. We talked about the clash that we're going to be talking about and kind of how you're helping out payers and providers, which I think is interesting that you work on both sides. But before we go there, tell us a little bit about yourself and 3Pillar.
So I've been in healthcare the last 15 years, kind of bouncing between healthcare tech and healthcare consulting, always in more strategy focused roles, and got tired of making 100-page decks that didn't go anywhere because of the underlying like old tech stacks, so I was working at a regional payer, and the VPs were sharp. They knew what to do. They had their action plans. We just couldn't move it forward because there were massive underlying, old antiquated tech
Technical
systems. So
debt.
the 3Pillar that, we help healthcare orgs modernize their tech stack so that they can innovate and bring new products to life. That's what we do. We work with payers, providers, health IT, SaaS companies.
Yeah, that's interesting. Well, we're going to dive into some of that. And yeah, I think you're right. There's so much technical debt in healthcare. I was talking with someone, I was like, has a new payer or a new provider been launched in the last 2 decades, 3 decades, 5 decades? Like, no, a couple payers maybe, right?
Yeah.
Anyway,
Yeah.
so they all have this technical debt, which is interesting. But I want to start off with what I kind of alluded to, which is this tension between payers and providers. Like, why is there that tension? And can something be done about it, or is it just the nature of the beast?
I think on the surface level, the tension is obvious to everyone who will listen here, right?
Yeah.
Health systems revenues are payers' expenses. I do think there's more nuance to that, of course. The payers, they face their own competitive dynamics, right? They need to sell to employers, they need to sell to individuals on the individual market, and so they're under pressure to how do you keep premiums low, right? If they approve every treatment, that's going to drive up costs in the end, and they pass that along as premiums. So that's the tension, right? The tension is ultimately payers take the heat for being the bad guys. And I've worked with payers. I understand that. But ultimately, it is employers and individuals want low premiums, and that means that not everything's going to be approved. I think that where that how that expresses itself is you have prior auths, med policies where not everything is approved, not everything is denied. And the complication is we're not a single payer system, right? If you're a health system, if you own your own practice, you're working with a dozen payers regularly, and then there's a long tail of smaller payers, and they all have their different medical policies, right? So they're
Yeah.
all going to approve, you know, is an ApoB, you want to get an ApoB test, is that going to get reimbursed? Maybe, but there's a matrix of different diagnostic codes. And I think the thing that creates a lot of frustration is those rules are not transparent. They're not easily understood by the provider in the moment. What is going to be approved? What's going to be denied? I think that's where I see the opportunity. But yeah, I mean, that the conflict is a bit in just the nature of health insurance is
Sure.
we all want low premiums when we're healthy. And then of course, as you're sick, you want everything covered, which is natural.
Yeah. No, and I think you're right. I think you described it perfectly. One person's cost is another person's revenue, which I think is at the crux of this challenge. But to be fair, there are areas to me that, they could both save. The payer doesn't want to have the provider refiling the claim 7 times and burning up resources on their end, right? Especially for something that they're going to pay, but they just did
Right.
something wrong, right? So, what are some areas that you see that payers and providers can both win, in this complicated dance of friendship, if you will?
So, Chris Severin, I believe is his last name. He's the founder and CEO of Turquoise.
Uh-huh.
He said something that always stuck with me, which is, there's going to be a fight, but it can be a more efficient fight,
Hmm.
right? To exactly what you said, like if a claim is eventually going to be paid, do we need all the back and forth?
Hmm.
Um, I think one thing I'm intrigued by, and we're starting to have a conversation with a regional payer about this, is the opportunity to streamline the opportunity for payers to streamline the reimbursement process, speed up payment, make it easier to pay, in exchange for lower rates and in
Hmm.
exchange for network participation, right? There's a few Blues plans already who have largely done away with prior auths for primary care doctors.
Hmm.
And one of having worked with regional plans in particular, they often pride themselves in their relationship with the local provider networks, right? They go to the same country clubs, they belong to the same charitable orgs, like they're in the same community, like they have a better relationship. And I think one of the things that is interesting to me, a concept that we're exploring with one payer, is is how do you make these medical policies and essentially your algorithm for what you're going to approve and deny, how do you make that transparent? How do you bring that to the point of care so that the physician isn't creating a bad experience for your member, right? The physician isn't saying, cool, we're going to, like, I want to do this treatment only to find out later it requires a prior auth. And now your member is frustrated at you. They do something only for it to be denied, and now they're trying to bounce bill your member for the full cost. um, I think the opportunity is to take those medical policies, which right now are buried in 200-page PDFs, and actually make that understandable at the point of care, for your members. As a patient, this is like my dream.
Yeah.
Is in the moment. We've all been there where your clinician's giving you or your son, hey, here's the care plan, and you're just like starting to sweat on the inside, right? Of like, what's this going to cost me?
Yep.
And it's on the payer, I think, to do a better job bringing that to the point of care. The providers are, they're nervous about sharing that, and often don't have that data available in real time.
Well, I think you highlighted the challenge, I think, which is that they're on legacy technology.
Yeah.
So talk to us, you've suffered through the pains of the legacy technology and how that prevents some innovation from happening. How should payers be approaching kind of platform modernization?
So, yeah, I mean, I think I think the threat is twofold. Or, thinking especially about regional payers versus the national payers are ahead, right? Like they have the money and the scale to invest in tech teams to acquire. They're just ahead from a technology point of view, as opposed to regional payers who might still have on-premise servers. They haven't moved to the cloud yet, and I think the consequence of that is, I think regional payers in many ways are becoming less competitive because of that. So I see two forces as I talk with payers. There's kind of two main forces in the market right now. One, everyone wants something bespoke to them, right? Everyone's self-insured now. Like if you're 200 employees and above, you're most likely self-insured. And so you're in control. You're paying the expenses yourself as a company. And so you want something that's very bespoke and custom to you from your TPA or the ASO plan. The national carriers have invested in tech stacks that have that flexibility, where they can configure insurance products, they can configure specific plans so that one company has access to the fertility benefit app, another company doesn't because that's not their population. They don't want to pay for that. And regional payers have really struggled to get modern tech stacks that can support that kind of flexibility. So that's one thing, just the other big kind of pressure that comes up in our conversation then is simplicity. So similarly, the big national carriers, they've vertically integrated in ways that create a much simpler experience for members
Hmm.
than a regional payer, where that connection between uh, your provider clinics, your PBM, your digital health apps, it's not seamless. The data doesn't flow. So you kind of have to start at the most basic level of how do you create a data platform that allows you to have a source of truth, to then create kind of a unified operating system or start connecting data. I'll just share one story. I shadowed the call service reps at a regional payer, and they were live in 5 different systems, right? Going into the pop health system, going into facets, the claim system, going trying to piece together this answer for the member. And in this case, they were going into like the live instance of facets, right? Where if they
Wow.
change something, they'd be like, that's terrifying. So creating that kind of like unified source of truth, creating an operating system where you don't have to email the pop health team. You can just send over something through a workflow. Uh, that's where the opportunity is.
Interesting. And do you think the regional, payers are not investing it because they don't have the cash or because they don't have the vision? And because I mean, to me, it feels like if they don't invest in it, then the gap is going to become bigger, and eventually they're just going to be acquired because they're not going to survive. Like why aren't they investing in this? Because it feels like to me a bit of a survival question if they don't invest in it, which we saw across so many other industries.
I think it's cash, but it's also capacity.
Hmm.
So, you know, regional payers especially, they're not built to be software organizations. Um, their specialty is building networks and having an actuarial team and
Mhm.
clinical experts, and so their IT orgs are just completely swamped and buried and don't have the capacity to do
Mm.
this kind of modernization. May not have the experience necessarily to do this kind of modernization. Um, that's what I've seen.
Yeah.
That's where the challenge is.
Well, and I guess that's why it makes sense for them to partner with someone who's done it, because you're right. I've seen the same in my own experiences that they knew the actuarial, some better than others, but like, and they knew how to create a network and to reach out to doctors, but they weren't tech people, and they didn't realize how important that tech stack was. So they needed to partner with someone else to do that. That's interesting. You mentioned something else pretty interesting as far as when we were talking about denials. What can be done to help providers avoid all these payer denials? So we talked about the payer side. Let's talk about the provider side a little and some of the work 3 Pillar does with providers to help them avoid these denials from the payers.
So I had back in 2018, I took a shot. I built an RCM startup, worked with this regional urgent care chain, spent a lot of time with their back office, and they had coders, right? Like medical billing coders who were reviewing claims before they went out, working denials, and the expertise was in their head, right? Like that's where all the institutional knowledge was.
Yep.
And I think that the complexity, there's two levels of complexity, right? One level of complexity is purely submitting the 271 eligibility. It's like, hey, do you need all 3 zeros in the member ID number before it starts? For this payer, yes. For that payer, if you don't include the middle initial, it won't go through. So there's that level of complexity, which these medical billers, like, they just know that. And then there's also, of course, the huge complex matrix of which diagnostic codes need to be matched to which CPT codes. And I think I think the risk is a couple of things. One, these people are going to retire and they're going to take all that institutional knowledge with them. Second, generally reimbursements have been flat. Like they're not growing as fast as labor inflation, and you have extremely manual processes, right? So the work we've been doing on this side with providers is looking at how do you create tools to essentially mine your historic claims to reverse engineer each payer's algorithm. So, and then institutionalize that, right? So we know that for this diagnostic code, this CPT code will not be reimbursed. It was denied. We're going to flag that not in the mind of the medical
Biller's
biller.
mind.
We're not going to try to do trainings to the clinicians to remind them, hey, like that's a game you're not going to win. But if you can systematize, hey, we've examined all your past claims, we've examined, we ran an AI bot across this 200-page PDF with all the medical policies from the payer, and now we're creating that algorithm, and then we're going to fine tune it so that you're not submitting. There's a flag that comes up. Hey, this probably isn't going to be approved. I think the dream is that gets pulled forward to the point of care, right? Where there's obviously it's very hot space right now. The DAX and all these medical scribes.
Yep.
What I'm excited about is tying that real time transcription to an RCM intelligence engine where it can even flag, hey, the care plan you're discussing is not going to be something that's going to be approved based on what we know about this payer. Bring that forward to the moment of coding when the clinician's creating the claim. You get a flag, hey, this is going to be denied. Someone from the back office is going to come to you in a month and ask you to change it anyway. Just change it now. This diagnostic code won't work. I think that's the opportunity for health systems.
Interesting. I want to talk about the point of care in a minute, but I think it's crazy to think that no one has done this really well as far as what you said, which is that, 3Pillar with your clients is reverse engineered the payer algorithm. Like it just makes common sense. Like, oh yeah, let's do an algorithm similar to theirs so we know and can predict, I mean, obviously it's a prediction, but the what's going to be denied ahead of time. And it makes sense that it's nice that 3Pillar works across payer and provider. So both sides of it, which is a powerful thing. It's amazing someone hasn't done that. And then to your point, how do you push it to the point of care? Is it going to go through the EHR? Is it going to go through these new ambient clinical voice that you talked about, the medical AI scribes, however you want to call them? How do you push that to the point of care? And it's also what information needs to be pushed, right? I think that's the other challenge with it is, okay, we did this with SDOH. I don't know if you social determinants of health. We can push it to the provider and say, hey, guess what? This person can't afford that medication, but what does the provider change, right? Like in this case, they probably can change some things, but they have to have the right information to be able to change it, right?
This is the challenge. Like you hit the nail on the head. Some of these just using the like clinical ambient clinical documentation tools. Some of them have announced partnerships with Epic, with Cerner. They're going to be directly integrated. Some of them are trying to create really appealing, apps that sit separately, but you can import relatively easily into the EMR. A lot of our work is with, we do some work for health systems, but a lot of our work is with specialty groups and the EMRs that support them. Right. And there you also have a long tail of different providers, EMR providers. It's a challenge. A lot of those EMRs, they've historically not built very open environments. So we work with a couple of those kind of outpatient focused EMRs to help them integrate with new experiences, new partners. I, from what I've seen, bringing this information to the point of creating the claim, that's starting to happen. Bringing it to the real time interaction, that's my dream. That's not reality yet. No one's doing that quite yet.
Interesting. Well, I mean, yeah, there's so much that we could help billers as well. And to your point, a lot of them can't even hire enough. So we need
Yeah.
some technology to help improve that efficiency. So that makes a lot of sense. You know, I think it would be, we couldn't do an IT innovation in the provider payer space without mentioning some AI. So, how do you see AI kind of impacting this? Are there some examples of using AI to make this experience better, whether it's the financial experience for the provider or whether it's the experience of the member with the payer? What are some examples you see in Three Pillars doing to use AI to help these organizations?
So we're using AI to do a lot of data mining
Hmm.
on behalf of our clients, right? Being able to go into a huge data set, like what are the past few years of claims, right? What was denied, what was paid, what required a prior auth that we didn't realize, and using AI to extract those rules. Um, and that technology is moving forward, but that's been established, and we've been doing that for years. What's really new, of course, is Gen AI.
Yeah.
And there the application often is being able to have like a real-time support that you can interact and communicate with. So we're working with a payer. We just built our first iteration of a payer chatbot to be able to go back to what we spoke about 10 minutes ago, that customer service rep who's trying to do right by this member, trying to give them an estimate of what care may cost, or is this bill accurate that they got from the health system. And it's hard because there's a ton of data that has to be processed in real time. What's the fee schedule? What's the provider directory? How does your plan work? What are all the medical policies? How much of your plan have you used? Where are that all that data lives in separate places, and it just takes math. Like, for customer service to combine all that in real time is complicated. So we built version 1 of our chatbot, which takes all that information, can combine it to provide real time answers. The challenge, of course, is hallucinations. Like, that's going to be everyone's not first concern. Is this data accurate? Um, my layman's understanding of what our very smart AI engineers are doing is kind of where the new technology is going is using knowledge graphs. So it's understanding intent of what is the person asking for, and then not letting the AI bot just go out to the universe of knowledge, but directing them to a very discrete set of data. The provider directory. This is the only place you can search in order to pull the right information. So I'm excited about that because we've all been there where it's like, I just want to know if this particular provider, that's this urgent care that's still open at 10 p.m., are they in network? I can't figure that out on the app. There's not a search function. The call line doesn't open until 8 a.m. tomorrow. And I think that's actually a really big opportunity.
Yeah. It sounds like you're doing, like, I heard someone describe it as, you describe knowledge graphs for getting the right info, but to avoid hallucinations, you're only using Gen AI for what it's good at, which is language and summary, not knowledge, which I think is, there's an interesting experience there. But, I was thinking about your example of the chatbot. A human going across 5 systems, you might as well, you just don't want to do that, right? It's hard for you to do. But a chatbot across 5 systems, it's hard to hook up, probably. You're doing the hard work of hooking up to all those sources, but it doesn't care. You could hook it up to 10 systems if it, like, whereas a human, it can't, right? So I think that's interesting that a chatbot can scale to however many legacy systems it needs to Sure, it's harder to implement in the beginning, but the output is fine, and it doesn't care how many systems you hook up to, which I think is an interesting comparison, and the value of a chatbot or AI tool like that.
Yep, absolutely. And you hit the nail on the head. Like, we'll have these conversations about really cool use cases and how we would build that chatbot, but then the conversation always goes to, well, how do we get the right data? And that's where our kind of ultimately I'm here to help payers and providers move forward. And so that's why at 3Pillar it's nice, because it's like, cool, we have a bunch of people who specialize in data engineering and integration, so we'll take care of that.
Yeah, interesting. I always like asking this to people, and I'd love to hear your perspective. Are are payers and providers really ready to improve the experience for members and patients, or like it seems like they don't care because they haven't done it right. So like, why should this be an important part of their work, improving the member or the patient experience?
There are technical challenges, and there are business model challenges. And the I think the business model challenges are shifting towards allowing the tech to solve these problems. Like, you're absolutely right. Some of the really cool clinical things we could be doing, we don't, because we're in a fee for service world. Our when I've worked with payers, we can't make the cool investments that lead to ROI in 5 years, because we're operating on 1 year timescales. And on the commercial side, we're selling to the employer, not the member. I think I'm optimistic that there's a couple kind of macro factors pushing this. One, the labor market is very tight. And what matters to the VP of benefits at a self-insured employer is flipped in the last couple of years, according to like Aon and Mercer, the studies they've done. It's gone from cost being the number one concern to experience being the number one concern. Like, I want this to be an attractive benefit that helps me attract and retain employees. That means I want a modern app experience for my employees. I don't want to get emails that they're frustrated because they can't, they got this bill and they don't understand it and you're not helping. And then I think with Medicare Advantage becoming a little bit more competitive, still some growth in the individual market space. There you're competing on price, on premiums, but experience is also a large part of that. I think Oscar, they hit their bump, but now they're doing well, and part of the reason is people know that they have a better experience, right? Because they have a more modern tech stack.
Yeah, and that's going to push people forward. I think you're right, though. The employers is probably key. They're the ones that are footing the bill for it, and hearing the complaints and having their staff not in the office, which is well, or in their home working or whatever it is these days.
Right.
I think that's going to push it forward. So, yeah, it's an exciting time. I think you're right, though, that the experience matters more than it ever did before. There's more competition, especially with virtual, et cetera, as well. So, a number of macro trends there. Interesting. Well, Steve, this was a lot of fun. It's when I heard the premise and we started talking about this, I love the idea, because there is this like underlying animosity between providers and payers that just happens naturally because of the business models. But I'm seeing more and more people saying, but why is that? We should be able to work together, and we should be able to improve the experience for patients and the members.
Very last thought, it's very
Yeah.
buzzy, and I hope it's successful. I think what Glenn Tolman's doing with Transcarent, he's essentially trying to intermediate the payer, create a new network. His whole premise to providers is join our network because we will pay you the same day you do service.
Yeah.
And that's his wedge. That's how he's building this network with the top, health systems and doctors. And I think that's, that's part of the opportunity. How do you make it? How do you escape this inevitable conflict and reduce provider abrasion and ultimately make the experience better for your members too, so that you can steer them to the right care and you're not creating confusion and delay that leads to frustration and worse outcomes.
Yeah. Well, and going back to where we started, the key is that platform modernization. How do you bridge the data from all that legacy tech to provide value and create the seamless experience that patients and members want? So, Steve, this was a lot of fun. I appreciate you taking time to talk with us and share your insights and perspectives. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Steve.
Thanks, John.